Hello everyone, welcome to Path to Excellence. In this video of lymph node cytology series, we are going to discuss the monotonous small cell pattern. In previous video, we have discussed polymorphous cell pattern in lymph node cytology. So now today, the topics which we are going to discuss are first definition and criteria for monotonous small cell pattern and the differential diagnosis of this pattern we are going to discuss one by one. So, what is monotonous small cell pattern? When will you call monotonous small cell pattern? So, by definition, predominance of uniform small lymphoid cells less than 12 micrometer. So, you have to compare it with either histiocyte nucleus, segmented neutrophil, or it is 1.5 to 2 times RB size. So, key cytological features is monotonous population, means there is lack of polymorphism. So, here you can see, here in this slide, you can see all the cells are similar to each other. So, this is called monotonous small cell population. So, what is the clinical significance? Always abnormal in enlarged lymph node, and it requires clinical as well as flow cytometry correlation. So, in Romanowski stain smear findings, cells are small, round lymphocyte and having very scant cytoplasm, and it is having dense clumped nuclei and it is having chromatin pattern called soccer ball appearance and having inconspicuous nucleoli. And background show sometimes smudge cells mainly in small cell lymphoma or CLL. So, architecturally there is loss of polymorphous population. So, what are the differential diagnoses? So, in benign condition, it is quotient or reactive lymph node and Castleman disease. And in neoplastic, common conditions are chronic lymphocytic leukemia or small lymphocytic lymphoma, which is most important for this pattern. Second is T cell CLL, which is rare, which is included in real classification. Third is lymphoplasmacytic lymphoma. In others, T cell histiocytic rich DLBCL also included in monomorphous pattern, and nodular lymphocyte predominant Hodgkin's lymphoma. Now, what is the diagnostic approach? So, first of all, the first step is morphology. So, first you have to decide whether this pattern is monomorphic or polymorphous and whether you can find smudge cell or not. Now, second thing, go for clinical correlation, age, lymphadenopathy, site size and numbers of lymph node as well as leukocytosis. And after that, flow cytometry and ancillary tests are helpful for the diagnosis. So, first of all, let us see inactive or quotient benign reactive lymph node. So, which is seen in resolving phase of reactive lymphoid hyperplasia and represent inactive or resting lymph node pattern, and it is generally post-reactive state. So, occurs after infection, inflammatory response and residual small lymphocytes persist and there is no acute immune stimulation. Clinically, patient is asymptomatic, there is isolated or regional lymphadenopathy, duration of lymphadenopathy more than 8 weeks generally, and if you see lymph node, it is less than 1 centimeter, oval form, mobile and non-confluent. Now, cytologically, cellular smear show only predominance of mature small lymphocytes which is having scant cytoplasm, clump chromatin and inconspicuous nucleoli. So, monotonous pattern is seen. And what is the clue? Whether it is reactive or not. So, occasional large lymphocytes and histiocytes are present. So, background is clean and no atypia, which suggests reactive process. So, immunophenotypically if we see, there is no monoclonality of B cell, no T cell gene rearrangement, and polyclonal population is seen. So, it confirms benign reactive process. So, this is here the smear showing predominant small round lymphocytes, and some cells show larger lymphoid cells, and if you find tingible body macrophages, then it suggests this reactive process. Now, second is Castleman disease, particularly hyaline vascular variant. So, it is also called angiofollicular lymph node hyperplasia, and you will find giant lymph node hyperplasia, and it is benign lymphoproliferative disorder. And if we remember histological features, most is germinal cell center twinning, where you find two germinal centers in one follicle. This is a most specific feature. Second thing, onion skinning of mantle zone. So, you will find layering of the cells, hyalinized germinal center, and the penetrating vessels you may find, that is called lollipop sign, and there is increased paracortical blood vessel proliferation. So, this is histological features of hyaline vascular type. So, what is the classification? So, it is heterogeneous group of disorder. There are three types. One is hyaline vascular, most common, it is localized. Second is plasma cell variant, and third is multicentric Castleman disease. And it is associated with human herpes virus infection 8, mostly this plasma cell and multicentric variant, and HIV infection. And sometimes this multicentric Castleman disease show plasma cell histology. So, it is divided like unicentric and multicentric. Before we stamp it as Castleman disease, we have to exclude all the infection related like EBV, HIV or TB related lymphadenopathy, autoimmune disease, as well as some lymphoma. And there are three types. One is poem associated MCD, second is idiopathic, and third is this Kaposi sarcoma virus and HHV associated this Castleman disease. And here common site is mediastinal lymph node. Others sometimes develop cervical and abdominal nodes too. Age is having wide range, and mostly this variant is common in younger patient. Lymph nodes are large up to 6 centimeter or more than that, and usually asymptomatic and may be symptoms due to compression like dysphagia, dyspnea or vascular compression. So, constitutional symptoms are rare. This is the disease classification having different features. So, you go through this for the Castleman disease. Now, cytologically, it shows predominantly small lymphocytes in hyperplastic mantle zone, and characteristic is branching hyalinized vessels. Germinal center fragments are seen in more than 50% area, and background is mostly polymorphous. And here additional features show follicular dendritic cells, some cells like plasmacytoid monocytes, immunoblasts, eosinophils, and rarely plasma cells. Mitosis is rare. So, overall pattern is polymorphous, but the small lymphocytes are predominant here. So, here in this cytological smear, you can see predominantly small lymphocytic cells are seen, and this is from mantle zone, hyperplastic mantle zone. So, when we find this, we have to go for immunophenotype and cytogenetics. So, here there will be no B cell monoclonality and T cell gene rearrangement. There is polyclonal population, and Ig heavy chain is germline. PCR gene is also a germline, and it confirms non-neoplastic nature. So, in differential diagnosis, we have to include reactive lymph node, small cell lymphoma, and important thymoma because it is generally present as a mediastinal mass. So, key clue is mantle zone lymphocyte, which resembles thymoma like Hassel corpuscle like pattern. Now, for the exam purpose, you have to remember most common localized Castleman disease is hyaline vascular variant, mediastinal mass, asymptomatic, thin Castleman, polymorphous smear, not monotonous like CLL, but 90% of lymphocytes are having a small lymphocytic pattern, branching hyalinized vessels and no clonality, which is reactive and benign process suggestive. Now, let us see BCL, this B cell chronic lymphocytic leukemia or SLL. So, here most common adult leukemia, which is CLL and SLL, it is indolent B cell neoplasm. When it is called CLL, when blood involvement is there, means when you find peripheral blood lymphocytosis, and SLL where lymph node involvement without leukocytosis is present, and usually bone marrow plus blood plus lymph node is involved. So, what is the role of FNAC? To confirm nodal involvement and to rule out Richter transformation. Now, clinically, mostly present in old age patient, male predominance, generalized lymphadenopathy, patient present with hepatosplenomegaly. Symptoms include fatigue, anemia, and Richter transformation in 5% of cases where there is sudden aggressive course and B symptoms present. So, core features include highly cellular smear showing monotonous small lymphocytes, scant cytoplasm, round nucleus, and coarse clump chromatin, which is called soccer ball or checkerboard appearance. So, here you can see this is a small lymphocytes having clumped chromatin where some light and dark areas are present resembling this soccer ball. So, this is a characteristic checkerboard or soccer ball nuclei pattern seen in this, and there is smudge cell and mitosis are rare. So, here in this Giemsa stain slide you can see soccer ball or checkerboard pattern appearance, alternative dark and light area in most of the cells. So, here you can identify this dark area, in between you can identify light area. So, this is classic soccer ball pattern of new chromatin, and these are the smudge cells. They are the cytoplasm of crushed cells in the peripheral smear in a case of CLL. Additional cell type you can find in this smear are prolymphocytes, which are intermediate size and prominent nucleolus. It is difficult to find sometimes or difficult to differentiate it from paraimmunoblast, which is larger cell having central nucleolus and pale cytoplasm. So, here you can identify larger cell which is paraimmunoblast type of cell. So, this is paraimmunoblast central nucleoli, and these are some prolymphocytic cells, and these are uh, lymphocytes. These are the cells of leukemia. So, this is absence of tingible body, macrophage in histiocytes, and mast cells may be present but not specific. So, this is monotonous cell pattern with some cells showing paraimmunoblast and prolymphocytic cells. Now, immunophenotypically, B cell markers like CD19 and 20 positive, CD5 positive, CD20 positive, 23 positive, and surface immunoglobulin, which is DIM expression, having DIM expression. Negative markers are CD10 and FMC7. So, diagnostic phenotype is CD5 positive, CD23 positive B cell is equal to CLL. Now, cytogenetics, if we see, deletion 13q14 show good prognosis, trisomy 12, deletion 17p, deletion 11q, it shows poor prognosis, and which is detected by FISH on FNAC material. So, differential diagnosis like reactive lymph node, follicular lymphoma grade 1 where nuclear cleaving is there, Mantle cell lymphoma where irregular nuclei CD5 positive but CD23 negative. T cell lymphoma and lymphoplasmacytic lymphoma where you find plasmacytoid cells. Now what is Reacher transformation? So it is normal cell which are converted into CLL cell and which is now undergoing to diffuse large B cell lymphoma. So, this is transformation to diffuse large B cell lymphoma where you find large atypical cells with prominent nucleoli, and you can see here these are the CLL cell and they are transformed into this large cell. So, this is diffuse large B cell lymphoma. Clinically it is showing rapid progression and poor prognosis. So, monotonous small cell lymphocyte, small lymphocytes suspect CLL, smudge cell is classic clue, 5 and CD23 is diagnostic, reactive node which is polymorphous, and Reacher's transformation where it is a emergency diagnosis. So, here you can have differential features of Castleman and CLL, SLL. Now, T cell chronic lymphocytic leukemia. So, this is rare mature T cell leukemia. Now, it is not included in current WHO classification, but in current WHO classification, it is as a precursor T cell neoplasm or neoplasm of immature T cells. This falls under real classification terminology. Now, by definition, this term is used in real classification and it is closest entity which is in WHO, which is T pro-lymphocytic leukemia, TPLL. It represents mature CD4 plus T cell leukemia with nodal involvement and without classic TPLL morphology in some cases. So, clinically adults are affected, more aggressive than BCLL and not curable. Organ involvement are bone marrow, lymph node, visceral organs and skin. Cytologically, you will find two patterns. One minority of the pattern is CLL like, means you will find small lymphocytes and resemble BCLL, but phenotypically it is different. Now, more common pattern which is TPLL like where cells are larger in size and characteristically irregular nuclear contour and prominent nucleoli with abundant cytoplasm. So, this nuclear irregularity differentiated from classic CLL-B CLL. So, here this is the T cell prolymphocytic leukemia where you find this irregular nuclear contour and cytoplasm. So, this is the T cell leukemia. So, immunophenotypically it is T cell marker positive 2, 3 and 5 CD4 predominantly seen and it confirmed T cell lineage. And cytogenetically inversion 14, 11q, q32 and trisomy 8q which is important for diagnosis as well as prognosis. So, key differential as we have discussed BCLL, SLL which is monotonous CD23 and 5 positive, uh, T pro-lymphocytic leukemia and other T cell lymphoma. So, immunophenotype is essential to differentiate this type of monotonous small cell pattern. So, key diagnostic points are it is rare entity, think when T cell phenotype but CLL like picture, more aggressive, irregular nuclei which is red flag and typically not seen in CLL, and definitive diagnosis is with the help of immunophenotyping. So, this is the differentiating table where you can have different markers, cytological and behavior differentiation. Now, lymphoplasmacytic lymphoma which is another pattern which shows mononuclear cell pattern and associated with Waldenstrom macroglobulinemia. So, here it is indolent B cell neoplasm composed of small lymphocytes, plasmacytoid lymphocytes and plasma cells. So, LPL which is lymphoplasmacytic lymphoma, it is tissue based disease and Waldenstrom macroglobulinemia, it is clinical syndrome which is associated with IgM paraproteinemia. So, both have same disease spectrum, but key hallmark is monoclonal IgM production. So, classically elderly patients, male are affected, organ mostly bone marrow, in 15% lymph nodes are involved and spleen, symptoms fatigue, weakness and anemia. IgM related effects which show first is hyperviscosity syndrome. So, patient present with this type of symptoms like blurred vision and CNS ischemia. Cryoglobulinemia which lead to Raynaud phenomenon and vasculitis, and peripheral neuropathy and bleeding tendency, and amyloidosis may occur. So, core features include cellular smear shows small lymphocytic cells along with plasmacytoid lymphocytes. So, this is the key feature, and plasma cell. And here characteristic features are Dutcher bodies which is intranuclear inclusion. So, nuclear here it is intranuclear inclusion which is called Dutcher body. Second is Russell body. Russell body which is a cytoplasmic inclusion, and background show mast cells. So, key cytological clue we have to see for plasmacytoid differentiation which is diagnostic hint. So, what is plasmacytoid differentiation? You will find eccentric nucleus, basophilic cytoplasm and perinuclear Hof. So, this is eccentric nucleus. You will find perinuclear Hof, and it helps differentiate from CLL where you will not find plasmacytic differentiation. So, here in this smear you can identify most of the cells having eccentric nucleus and basophilic cytoplasm, dark cytoplasm. So, these are the cells which show plasmacytoid differentiation. Now, what is Dutcher body? So, here you can see this is the plasma cell, and this is having perinuclear Hof, and this is Dutcher body means intranuclear inclusion, and here the Russell body show intracytoplasmic vacuolization. So, this is Russell body. And what is Mott cell? Mott cell which show this type of inclusion bodies in the cytoplasm of the cell which is due to excessive IgM production by the plasma cell. Immunophenotype CD19, 20 and 22 positive. Other markers like 25, 27 and FMC7 positive. Negative are CD5, 10 and CD23 is negative or dim. Plasma cell which is CD38 and CD138 and cytoplasmic IgM is positive. So, this is the hallmark of this disease, and there is no surface immunoglobulin is there. And cytogenetically it is deletion 6q which is helpful supportive feature. So, differential include CLL, SLL, multiple myeloma where more plasma cells and bony lesions are there, and some other small B cell lymphomas. So, IgM alone is not diagnostic, we have to see for immunophenotyping also. And what are the complications? It can transform to DLBCL type centroblastic in immunoblastic type, and it indicates aggressive disease and poor prognosis. So, plasmacytoid lymphocytes are hallmark of this disease, IgM paraproteinemia which lead to hyperviscosity, and due to this you will find Dutcher bodies, Russell bodies, Mott cells. It is CD5 and CD10 negative, and sometimes you will find mast cells which is supportive feature. Now, T cell histiocytic rich diffuse large B cell lymphoma. So, here it is a variant of diffuse DLBCL, and it is highly aggressive lymphoma characterized by few large neoplastic cells, and background is rich in T cells and histiocytes. So, if we see DLBCL having variant like centroblastic, immunoblastic, plasmablastic, anaplastic, and in this category nuclear pattern, it is T cell histocyte rich variant. It can arise de novo or it can be from the transformation of CLL or LPL or follicular lymphoma or marginal zone lymphoma. Uncommon variant, young patients, male, are generally affected. Patient present as a generalized lymphadenopathy, epinosplenomegaly, bone marrow involvement and B symptoms, and treatment is similar to other DLBCLs. And cytologically, here you will think why this category DLBCL is included in this mononuclear cell pattern. But here the large neoplastic cells are generally less than 10%. So we can easily miss. And the larger cell population may be centroblast, immunoblast or Ritz-Sternberg like cells in this large neoplastic cell pattern. So this diagnostic pitfall is it is having low tumor cell yield, and background show generally 90% of the cells show reactive T cells, mostly small mature lymphocytes. So you will easily miss if you do not go for careful search, right? And you may find histiocyte like epithelioid cells also, so it will give us false impression of reactive process. So this is why, that is why this is included in this category, because of monotonous population with less than 10% neoplastic cells. So this is the histological section, where in this section you can see these are the small lymphocytes and these are the histiocytic epithelioid look like collection, but the characteristic feature of this cell, this is a T cell histiocytic rich BLCL, is these are the large atypical cells. They are very few in number and we can easily miss if we do not go for careful search, right? So this is immunophenotypically, these neoplastic large cells are CD20 positive, CD15, 30 and EBV negative, and background shows T cell marker CD3 positive. Mixed population is there, malignant B cells and reactive T cells are seen. So differential diagnosis include reactive lymphoid hyperplasia, lymphocyte predominant Hodgkin's lymphoma LPHL, small cell lymphomas, and key confusion is due to predominance of small lymphocytes. So search carefully for large atypical cells. Background T cell can mask malignancy, and whenever diffuse pattern favor TCR DLBCL. So always correlate with immunophenotyping and with clinical features. Now Hodgkin's lymphoma. Here typically lymphocyte predominant type, which is LPHL or nodular LPHL. So this is subtype of Hodgkin's lymphoma, also called nodular lymphocyte predominant Hodgkin's lymphoma. It is unique entity having B cell origin and indolent behavior. Classification, if we see WHO classification, this is two category of Hodgkin's, like this NL nodular Hodgkin's and classic Hodgkin's lymphoma. So this LPHL is germinal center B cell neoplasm and temporally group under Hodgkin's lymphoma. Clinically, 6% of HL cases shows these features. Fourth decade is peak symptoms, and presentation localized lymphadenopathy, mostly cervical and supraclavicular. Stage 1 and 2 disease common, and here mediastinal involvement is rare, B symptoms are rare, so it is having indolent course and good prognosis. Cytologically, if we see neoplastic cell, it is called LNH cells or popcorn cells. So here you can see these are the lymphocytic predominant uh, pattern where you find this type of popcorn cells having pale cytoplasm, multilobed convoluted nucleus, thin nuclear membrane, vesicular chromatin, small inconspicuous nucleolus. So classic description is popcorn cells. In Hodgkin's, you can find this type of different neoplastic cells, like this is classic RS cells, mononuclear cell variant where it is called Hodgkin's cell, water clear cytoplasm which is called lacunar cell variant, mummified cell variant, and anaplastic or pleomorphic cell pattern, and here it is popcorn cell is predominant. So, in background predominantly small lymphocytes are present and scattered histiocytes and follicular dendritic cells may be present, and it may show reactive germinal center elements. But here eosinophils, neutrophils, plasma cells are absent, which help differentiate from classical Hodgkin's lymphoma. So here in this smear you can see this is the background cells showing a small lymphocytic pattern, but this is the neoplastic cell where it is large in size and convoluted nucleus like a popcorn. So this is called popcorn cells. So this is again a smear of this Hodgkin's lymphoma type, where this is the popcorn cell pattern and predominantly lymphocytes. So this is the classic popcorn cell in the Hodgkin's LPHL. This is again a very good popcorn cell appearance of this neoplastic cell. So immunophenotypically, it is showing B cell marker like CD20, 22 and 79 A positive, BCL6, PAX5 and CD45 also positive. Classically, it is CD15 and 30 negative or maybe positive and EBV negative. So, it confirms B cell origin, which is unlike classical HL where you find CD15, 30 positive mostly. Cytogenetically, Ig immunoglobulin gene rearrangement present. Clonal abnormalities are common and it support neoplastic B cell nature. So differential diagnosis include classic HL, which is showing RS cells and eosinophils, T cell histiocytic rich DLBCL, which is having diffuse pattern, aggressive course, and reactive follicular hyperplasia where polymorphous population is there. So we require cytology plus immunohistochemistry and excision biopsy for confirmation. So this is the table showing differentiating feature between this LPHL and TCR DLBCL. So whenever you find popcorn cells, this is the hallmark of this disease. CD20 positive, 15 negative, CD30 negative, it is diagnostic, no eosinophils and nodular pattern is key clue. And there is risk of transformation to DLBCL. So this is a complete revision of this table showing complete revision of this monotonous small cell pattern. So go through these features of all these diseases so that whenever you go for microscopy of lymph node smear and whenever you find monotonous small cell pattern, you definitely uh, go through this feature so that you can easily diagnose small cell pattern of various diseases. So I hope if you found this video helpful, please like, share and subscribe this channel for more such video, and in next topic we will discuss monotonous intermediate size cell pattern. So keep watching and thank you for watching.